Let's talk with Velda now about her heart journey and what brought her here today. And then again, we can open it up for questions. Miss Velda, are you ready?
I'm ready.
All right, go for it.
Well, my story is entirely different. All my life I had a heart murmur from the time I don't know how old. I've never had any pain, but as I got older, I've always been active. I've been a walker. By the way, I'm 91 years old. I've always been a walker. I've always been active. But through the last years or so, my asthma seemed to kick up. So I was treating that, and I keep on walking. Well, I went in for a checkup, and they'd been watching my heart valve because it was closing off. Well, the last time I went in, I had an opening about the size of a lead pencil. Never had a pain, just short of breath, always short of breath. So they said, you're going to have something done. I wanted to wait until they got the heart unit here at Luther, the new unit where they could do surgery. They said, no, you can't wait that long. So I had to go to Rochester. Well, that was quite an experience. I got there on a Wednesday. I got there Wednesday morning, and I had surgery. I came home Friday, if you could believe it. I had the new surgery. It's called yeah. And all I had was 2 openings in my thigh or groin. No pain. I never had a pain pill. It was like a walk in the park.
Wow.
And I came out of the surgery, and I wasn't short-winded. I've not had an asthma attack since. I seem to believe that maybe it was my heart instead of the asthma that I was treating for years. And one reason I think they put that off so long, I have unusually high good cholesterol. So they just let me float along, just do what you want to do. I would recommend this kind of surgery to anyone. There was just nothing to it. In fact, my family, who are so thoughtful, forgot to keep track how long I was in the operating room. No one knows how long it took. So I feel great. I exercise. I did go for the rehab or the exercise down at Luther Hospital. But I've always been a walker, so exercise. And we live in a 2-story house. I would recommend that one to anyone. So don't be afraid. That's of going in and checking. And don't be afraid of the surgery because they certainly know what they're doing.
Thank you, Velda. I think you're officially my hero now. You are, wow. And too bad Mayo doesn't have like a video camera here to get you on for a commercial for them, because that was a rave review. So let's turn it now to Dr. Carmody. We have a slide with an animation showing the TAVR surgery that she was talking about. Doctor, can you walk us through this slide and explain how it works?
Sure. You see the heart in the middle and the major vessel coming out of the aorta, and it splits in the pelvis to 2 big vessels that then split down into the leg. We go into that leg with a catheter. We start with a wire, and we will place that wire initially into one of the cusps of the aorta that gives us a marker, and we bring up another that goes through the valve itself. And this is one of roughly 4 or 5 approaches we can do for this particular event. And we feed it through the heart, and once we go through the valve, we then bring it out in the measured valve, and we deploy it. And as Velda said, actually the surgery itself is the tip of the iceberg. It's a big process of, you went through a lot of tests to get to that point. You went through a lot of discussions and a lot of measurements. And we have a lot of people in the room. And the buildup is very, very, very big, and the surgery takes us about 15 to 20 minutes to do it.
Wow.
And so yeah, once you get into the surgery, you're not in there very long. And then the great thing about it is, as you can see, the heart is beating in the cartoon animation. We don't use the heart-lung machine. We're working inside the heart, and back in the 50s, we were trying to figure out how to get inside the heart. We could fix things outside it, and we had to come up with a big fancy heart-lung machine, which we still use today. This isn't for everybody, but Dr. Alain Cribier in France came out with it in 2002, rudimentary form. It's progressed, and we had to start with very, very high-risk, unoperable patients. We stratify them based on their medical history, what they bring to the table. We proved it in Europe. It came over to the United States, and that particular group of patients did very, very well in a 1-year mortality. We then extended it down to our high-risk patients based on an STS stratifying score, and they as well are doing very, very well. They get out of the hospital very quick. They're back on the lawnmower in a week, and they're back in the saddle. It's wonderful. So technology has really brought this a long way. We've already extended it, and we're working on the mitral valve right now. I think in 10 years it'll be down into the lower risk category. There's still small things. There's a risk of pacemaker. Permanent pacemaker is a little higher risk with this particular procedure. Perivalvular leak tends to be there a little bit. We're on an early generation of valves that we're using, but it's extremely exciting, and it's only going to get better and better.
How cool. Well, Dr. Carmody, can you talk about the importance of cardiac rehab? So after surgery, why is this so key?
Well, anytime we work on the core of the body, that would be your chest or abdomen, different than working on legs, arms, and neck, it really zaps the patient. In just this particular procedure, although it was probably quick for you, you probably felt a little, down and out for a little bit. And they'll go home and they, as you mentioned earlier, how many people pick something else to do than exercise? There's always an excuse not to do it. So after we have any kind of surgical procedure, whether it's open or closed such as this, or even stents and so forth, it really zaps you a little bit. You're tired. Your heart's happy, but the body's zapped. And so if we leave it up to you to just sit there and get down on your treadmill or whatnot, you'll find 1,000 other things you can do. So we set up a rehab program to make you get into the gym, physical therapy, see them 2-3 times a week. We get your report card, we see that you're going and all that good stuff and check it off. And then, usually within weeks of the surgery, you're back in the saddle and you don't need it anymore. The name of the procedure is transaortic valve replacement, otherwise known as TAVR, TAVR. If you read up this in Google, you'd see TAVI, transaortic valve insertion, because that's really what we're doing. We're not replacing your valve. You remember the animation that Dr. Calvin showed you of the plaque in the vessel and how they went in there with a balloon and squished it to the side? It's exactly what we're doing with the valve, except that stent that he showed you in there. Instead, the stent is just like what we use for TAVR, but there's a valve inside that stent, sutured right to the stent. So we squish the hard plaque aside, and in there is a functioning valve. Your valve is still there, just squished to the side, and it's called TAVR. Your second part of your question was, is there a way of us removing it? For the coronaries or for the valve?
Any place in my body where I've got plaque built up.
Yeah, that's tough.
It out before we have to go through this stuff.
Yeah.
Well,
on your own.
You can stabilize it. We can't remove it like liquid plumber. That would be awesome. Take a pill and just wash out the pipes. But they're working on that. High density lipoprotein in NHI. But will we see it anytime soon? I don't know. But we can stabilize it on those statin drugs we're taking. We don't want them to break off and go away. Certainly you can keep it from progressing by changing lifestyle, changing your diet. Shrinking it is asking a lot, but stabilizing it's huge, and keeping it from growing any bigger is huge. In In the open technique, we clean that old valve out. When this first came out in 2002, actually it was 2004 when he presented it at our Society of Thoracic Surgery down in Tampa, and we all thought he was crazy when he squishing this plaque aside, and your brain's just north of there. So we were questioning that. But it's the technology, the industry got involved. They've come up with some great accessories to come along to protect you, the patient. But cleaning it out, we do it directly in the coronaries. There are some roto-rootering they'll do, but that's the last kind of things that they don't look forward to doing in the coronaries. We just push it aside.